Hi, I'm Amy Reyes. In this week's News Roundup from Rheumatology Network, we feature a study that finds patients with axial spondyloarthritis who smoke may be more likely to have joint inflammation. We conducted a Q&A with the study author who is from King's College Hospital in London. You can see it online at rheumatologynetwork.com. And we also published a Q&A with a physician from the University of Washington who says that patients with axial spondyloarthritis may be more susceptible to higher disease activity if they are overweight or obese. And we highlighted a study published in RMD Open that finds Actemra may be associated with increased GI ruptures in rheumatoid arthritis patients. And how well versed are you in treat to target in rheumatoid arthritis? You can test your knowledge in a quiz we posted online this week at rheumatologynetwork.com. And in today's one-on-one interview, we talk with Dr. Jeffrey Sparks from Brigham and Women's Hospital in Boston. He recently presented a study at the International Autoimmune Summit that addresses the importance of interdisciplinary collaborations in treating rheumatic disease patients with interstitial lung disease. Welcome, Dr. Sparks.
My name is Dr. Jeffrey Sparks. I'm a rheumatologist and clinical researcher at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. And I have a particular interest in the role of the lung and pathogenesis and outcome of systemic rheumatic diseases, in particular rheumatoid arthritis.
Well, welcome to Rheumatology Network. I appreciate your time today. So I invited you here today to talk about your recent presentation at the Autoimmune Summit, a meeting that was held virtually this summer. Your area of expertise, just as you said, is rheumatoid arthritis and pulmonary diseases. And in your presentation, you talked about the importance of recognizing this as an interdisciplinary condition. So let's begin by summarizing your presentation.
Sure, and thank you again for having me. And it was also great to present this topic at the Interdisciplinary Autoimmune Summit. As you know, most things were virtual this time of year, so we were glad that this could happen even if not in person. So I had a big topic, pulmonary manifestations of rheumatic diseases, and something I could have talked about for a long time, but we broadly talked about the approach to diagnosis of pulmonary manifestations of rheumatic diseases, what sort of symptoms patients might have, what the differential diagnosis is, what kind of modalities you might think about for imaging and monitoring. We then went into disease-specific characteristics about pulmonary manifestations for rheumatic diseases, in particular rheumatoid arthritis, systemic sclerosis, ANCA vasculitis, lupus, and tried to survey the kind of different pulmonary manifestations that might expect. For instance, in systemic sclerosis and rheumatoid arthritis, you might expect interstitial lung disease, whereas in ANCA-associated vasculitis, this can present with diffuse alveolar hemorrhage. We then talked about the management approach as far as how the medications you might think about for treating pulmonary manifestations of rheumatic disease, such as rituximab, mycophenolate mofetil, and the antifibrotics, and then also talked about the controversy about some of the medications that might either have a positive or negative effect on pulmonary manifestations of rheumatic diseases. And that really highlights some of the gaps in the literature as far as some of the difficulties in diagnosing and treating these patients that are obviously quite complex.
Mm-hmm. So it is complex, just as you said, it manifests differently in patients with different rheumatic conditions. In a rheumatoid arthritis patient, for example, what symptoms might they have in the early stage that might suggest the presence of some kind of pulmonary manifestation?
Yeah, the typical symptoms of interstitial lung disease within rheumatoid arthritis would be dyspnea, typically a dry cough, sometimes chest pain. But as you can see, these symptoms are quite nonspecific. So often this is guided by imaging to try to, for instance, computed tomography scans to really see features of interstitial lung disease. However, the quandary is that some patients may have some imaging abnormalities that are not necessarily diagnostic. and have these symptoms, and it can become difficult to understand whether the imaging abnormalities correlate with the symptoms, and maybe whether the people with mild imaging abnormalities might progress to something more severe. So I think that's in particular something that we're trying to shed some more light on in patients with rheumatoid arthritis.
Mm-hmm. So is imaging routine for rheumatoid arthritis patients for this condition then, for this very reason?
Well, we're actually doing research now to understand the role of screening for RA-related lung diseases. I think right now it's still kind of in the research sphere, but certainly it's pretty common for clinicians to obtain these scans for many different purposes. And so I think right now it's still to the point where many patients will get, chest imaging. There could be abnormalities, and it's a real, complex decision about how to diagnose and manage these patients, and often needs an interdisciplinary approach.
Mm-hmm.
I'll add that some other rheumatic diseases, in particular systemic sclerosis, actually have maybe a bit more solid evidence base about screening, given that patients with systemic sclerosis have a really high burden of subclinical disease, and many of these patients do progress to clinically significant interstitial lung disease.
Mm-hmm.
So it really varies by disease and patient.
I see. And then at what point then would a pulmonologist become involved in the care of the patient or the diagnosis?
That's a really good question. And, obviously everyone's local situation is a bit different. I think that this is, such a common issue that patients might have a pulmonary manifestation of a rheumatic disease, that it's nice to have some sort of relationship with an expert pulmonologist who's really comfortable in diagnosing and managing these patients, such that when some subtle imaging abnormalities come up, it would be good to run the case by and have an expert thoracic radiologist as well, to try to understand whether this would actually might need someone that needs to be evaluated in person, or need more dedicated imaging or serial follow-up. I will say that I have blessed with great pulmonary colleagues who I'm able to run cases by. So I think it's for me, I think you kind of need this as part of your arsenal, to have sort of these experts on your side, and also know that you as a rheumatologist, can't be the expert in everything, and having someone who's really thoughtfully thinking about the lung manifestations and would be a real help to many of the patients.
Mm-hmm.
Having said that, I think that there's plenty of patients who have mild imaging abnormalities that don't need $1 million workup and serial imaging, and we're trying to do our research to understand who are the right patients to really monitor closely.
Mm-hmm. I see. And there at Harvard, I understand you really emphasize that interdisciplinary approach to care, whether it's in rheumatic disease or other conditions. Because in rheumatology, patients with rheumatoid arthritis, they have so many symptoms, so many conditions affecting their organs, their kidneys, their heart. So one would think this is very, very important to recognize this and just open up the possibilities of just working with colleagues and improving patient outcomes in that way. Yeah.
Yeah, absolutely. I think rheumatoid arthritis has been a really fun disease area to work with because of just what you said. There's so much more that goes on than just inflammation in the joints. It's actually, quite fascinating to see sort of the effect of long-term inflammation on many organ systems. And, here in our group, we have, different providers who are interested in different aspects about the total burden of rheumatoid arthritis, whether it's related to osteoporosis, cardiovascular disease, dermatologic manifestations, neurologic manifestations, pulmonary manifestations. It really is a systemic disease, and we're blessed to have many different providers who are very interested in a lot of those different aspects here.
Mm-hmm. And in regards to, let's go back to talking about symptoms, manifestations of this pulmonary condition. And there are different stages, I imagine. So in evaluating a patient suspected of having, it's called ILS for short, right? Suspected of having
Interstitial lung disease.
Yeah, yeah.
Mm-hmm.
So in stage 1, what might you see in a patient that you might suspect of having this?
Well, we don't really have a staging system, unfortunately, yet. I would, unlike other disciplines where it's really clear how disease entities progress from, 1 to 4. Uh, these are things where it's an insidious onset, so it's
Mhm.
sometimes hard to catch people at the very beginning. And there's many patients who might sort of have very mild manifestations that may be asymptomatic. Maybe the symptoms are very mild. Maybe the imaging abnormalities are subtle. And while it's logical to think that those people always will progress, some people just sort of stay forever with, very mild symptoms, no symptoms, and mild imaging abnormalities. And then there's some people who seem to have a very severe clinical presentation where they have florid symptoms and really severe imaging abnormalities, and it really seems to have come on quickly.
Mhm.
And certainly there are some patients where you catch with mild symptoms or mild imaging abnormalities who do progress to the more severe form. And obviously there's a lot of work to be done about the natural history for these diseases. Um, and interstitial lung disease, we actually think is probably a collection of different subtypes, all of which have different natural history. So it's a fair amount of work to sort out. Within rheumatoid arthritis, which rheumatologists think is pretty common, but these are uncommon manifestations of an uncommon disease. So it's
Mhm.
it's not necessarily clear how people progress, and each patient I think kind of has their own journey through how this affects their quality of life and how it affects the structural progression of the lung.
Mhm. Hmm. Fascinating. So, how then is it treated in those early stages? I mean, in that early phase, and then is it progressive? Can you describe the treatment modalities that you would employ?
Yeah, well, actually, I think that's where it can become quite complex in patients who are, either asymptomatic or have mild symptoms and have mild imaging abnormalities. It's not actually clear at this point that early treatment is beneficial. Certainly, these patients can often have, they have rheumatoid arthritis, so many patients will have, active synovitis, and then they also have, some abnormality in their lung, and this is where the interdisciplinary approach can come, because there's some patients who have a dominant joint sort of course in their disease. Some patients might have mild joint involvement and a lot of lung involvement, and some patients might have both, and maybe they're concurrent as far as when one flares, the other is flaring, but sometimes patients can have a joint flare and their lungs are quiet, and vice versa. So you can see how it's really complex as far as how each patient needs to be managed. And so there's probably not a one size fits all solution. I think right now in rheumatoid arthritis, we're typically, being watchful in patients that have imaging abnormalities that don't seem to have much in the way of symptoms and have no functional abnormalities. But you can imagine that the point about when you would switch from watching to treating is variable and can depend on many factors related to the patient's symptoms and the rate of progression of the imaging and pulmonary function test abnormalities. So there's not a one size fits all approach. And even in patients where it's clear that they need to be treated, there's not really a clear first line therapy. Often we're trying to manage the medications that they're already on to make sure that they're not contributing to any pulmonary manifestation. But there's not a one size fits all one approach.
Hmm. I see. So it's a very much a individualized approach. Yeah,
Yes.
yeah, individualized medicine. Yeah, for these patients. And in terms of the prevalence of worst outcomes, which I assume would be mortality, how common is it for it to progress to that point? Uh,
That's a really good question, and another one that we've been very interested in. I think actually the approach that we've initially taken is to look to see what the cause of death in rheumatoid arthritis patients were. And we actually really expected cardiovascular disease to be the thing that was driving increased mortality in rheumatoid arthritis. And certainly we do see an important increased risk in cardiovascular disease, but the relative risk for respiratory mortality is really the thing that is most striking. So patients with rheumatoid arthritis, particularly patients with seropositive RA, have a 2 to 3-fold increased risk of respiratory mortality compared to the general population. And certainly patients with seropositive rheumatoid arthritis have an increased risk for respiratory mortality compared to seronegative rheumatoid arthritis. And then looking to see what really was the cause within respiratory mortality, it's related to COPD and interstitial lung disease. So COPD is not something to discount in patients with rheumatoid arthritis. Even in smoking, even accounting for smoking, rheumatoid arthritis patients with rheumatoid arthritis have a quite high rate of COPD. And we think that there might be actually, this could be a reflection of sort of a rheumatic manifestation causing airways disease. So I think airways disease is a really interesting and sort of emerging area within rheumatoid arthritis. But certainly patients with RA are more predisposed to interstitial lung disease, and then those patients do have a high mortality. So we've had some preliminary data in process now that's not published, but it's really quite striking that patients with interstitial lung disease have a really, poor survival. We're talking on the order of around 5 years compared to RA patients without interstitial lung disease.
Mm-hmm.
However, there's a wide spectrum of interstitial lung disease, and some of the data sets we use are really more skewed to identifying patients with severe ILD. So patients with mild imaging abnormalities that aren't symptomatic, that don't need treatment, those patients are probably not as at risk for bad outcomes as patients that are obviously requiring oxygen and, targeted treatment for their interstitial lung disease. So there's a wide spectrum, but it's clear that this is a real problem within rheumatoid arthritis. And probably with all the advances in rheumatoid arthritis, this is one of the issues that seems to have not really improved despite all the treatment advances.
Yeah. So you'll be presenting new data on this later this year at ACR.
Well, I hope. We'll see how the abstracts come out.
Okay. Well, this has been interesting. Would you like to leave us with any other final thoughts on ILD? Yeah.
Well, I think the real key is this interdisciplinary and individualized approach. It's not a one-size-fits-all solution, unfortunately. So again, try to understand what your local landscape is. Have an expert radiologist and pulmonologist who you can really think thoughtfully about cases. And, if the volume is high enough, you really think about, interdisciplinary conferences that meet periodically. That's certainly what we do at our institution. And don't discount this because, these patients really have worsened quality of life, worsened morbidity and mortality. So it's going to be something that's really going to help the patient to have your antenna up related to all the varied manifestations that can affect our patients.
Okay, on that note, well, thank you, Dr. Sparks, for joining us. I appreciate your time, and we look forward to learning more about this condition from you. So
You're welcome. Thanks again.
Okay. And back to you, Gina.